All right. So welcome to Take a Seat at the Table 2020. Let's talk mental health during COVID-19. We're going to address stigma, access, and disparities. So we're very excited about this. And clearly we got our technology figured out thanks to Ed. Bear with us as we move forward. But I think well, let me introduce myself. My name is Mary Garrison, and I'm a professor of social work at Millikan University and a licensed clinical social worker. And I'm also a board member of Kennedy Forum, Illinois, which is an entity that is actually sponsoring this event and focuses on addressing stigma and trying to have parity when we look at physical health and mental health. And there's a great deal advocating for individuals who are living with mental illness and substance use issues. So I'm really honored to be on that board. And a couple of years ago, we got really involved with something called On the Table. And we've kind of shifted this a bit to say, take a seat at the table. And it's a way to celebrate May as Mental Health Month. And here we are on the 28th day of May. And we're almost to the end, but we've been kind of talking and trying to really address and increase awareness during May. And we thought this would be a nice way to just have a conversation and not just talk about it in May. So I'm hoping this will kickstart you, but we need to talk about our mental health every day. And it should be really a focus of our everyday life. So thank you for being here. So we really want to focus on mental health today, and I have my great colleague here, Nicole Ekiss, who's going to introduce herself, and then we'll jump into the program, and at the end, we'll have some questions.
Well, as she said, I'm Nicole Ekiss. I'm a school social worker. First of all, thank you for being here. This is such an important discussion we're going to be having, so we're really excited that you're all here. For the next hour, we plan to engage you in discussion regarding mental health and COVID-19, specifically stigma surrounding mental health illness, access to care, and the racial disparities that exist for minorities facing mental health challenges. As you know, this is a Zoom event, and so we want to hear from you via the chat piece. So if you have questions or comments, feel free to put those into the chat, and we'll discuss those towards the end. At 7:30 or maybe a little after, since we got started a little bit late, we'll open it up for questions and comments so that it can be more interactive and we can hear from you guys.
And so, yeah, we wanted to kind of lay the foundation and, kind of ask the questions, why is this conversation so essential? So, when you look at prior COVID-19, the statistics really speak for themselves. You have about 1.5 million individuals, adults in Illinois living with a mental health condition. That's 13 times the population of Springfield. And so we look at there's 1 in 5 individuals in the United States that are impacted by mental illness.
Then if you look at who those people are, 50% of mental illness begins by age 14 and 75% by age 24. So this is something that's impacting people throughout their lifespan, starting very early. 1 out of every 8 emergency department visits involves a mental health or substance use condition.
And only about 4 in 10 individuals in Illinois with a mental health condition have received treatment in the past year. And almost 5 million people live in a mental health professional shortage area. So meaning there's not enough providers. So that's going to speak to that access piece. So you can see that with the stats we're giving you, there's a lot of need, but we're in a shortage area here and across our nation.
So the need, I think, when you look at why this is so important and why those shortages are so staggering, is depression is the #1 leading cause of disability in the world, and mental illness costs Americans $193.2 billion in lost earnings per year. About 2 million people with mental illness are booked into jails every year, and 1 American dies by suicide every 12 minutes. So looking at those statistics, this is such a vital conversation to be having. because those are obviously very concerning. So let's talk specifically about COVID-19 as it relates to our mental health.
So I'm going to start here in kind of the impact of mental health related directly as a result of COVID-19. We're all living in this really right across our world. So we've seen it across the globe, and it's something that's really had a significant impact. And early research that is already out there has revealed that 1/3 of Americans reported having mental health challenges and difficulties as a result of caused by COVID-19. So they may not have experienced a mental health issue or symptoms prior to COVID-19, or they may have been exacerbated due to COVID-19. And so, you know, this is significant. As what we know is this has been facing us since mid-March. We started seeing really here in the United States when we're the shutdowns and things are happening. And that's a pretty swift increase. This research is from mid-February to mid-March. So we already have seen that increase, and we're going to see the numbers more and more as we go. And so, you know, one of the questions that I was thinking about when I look at the research is what might this mean for individuals who are experiencing those new or increased symptoms? Why is that happening? What we're being faced with can really produce a lot of fear and anxiety. And maybe if we've had and lived with mental health issues and symptoms, we've had our coping mechanisms in place. And this is so new, we're in an unprecedented time, they may not be working right now, right? Everything, it's not like one thing just changed. Everything changed in our entire life. And so I may now need to think of something different and use a different way. It could also be exacerbated because I haven't had any symptoms, and now here I am developing them. So a recent study actually revealed, again, this mid-February to mid-March time period, that prescriptions for mental health medications filled per week jumped 21%. Specifically, anti-anxiety medication prescriptions increased by 34%, and antidepressants 19%. And then at the tail end of that, insomnia aid medications by 15%. That is in a 1-month period of time at the early onset of COVID here in the United States of what we were experiencing. And so I think that is really telling about what individuals may be dealing with, right? They may need more than their self-care strategies to manage their mental health, and they, you know, may need medication. And I want to say that medication is fine. It's okay to use medication, and I think there's a lot of stigma surrounding that. But this is a time where it might be right for you, might need to change or get on medication. And I think Nicole and I will talk about that a little bit personally later. And so we want individuals to feel they can seek that out. But really, when you look at COVID-19, the impact is really, really evident based on the early research that we're seeing. So the next piece is thinking about reduced access for all. For prior COVID, we've had problems with accessing mental health care for years across our country. So I talked about being a professional, an area that has professional shortages. And specifically, we see access reduced for minority and marginalized groups because there are no services in their area. Depending on where they're living, and the provider base is very low. So again, you're not having people a lot of times in rural areas, in maybe inner city areas, and not finding enough of them. Transportation, time, and cost can be barriers again for access for many. So that's been happening prior COVID. Now here we are. All living in this, what I'm hearing, you know, people say is the new normal, and I like to call it the temporary new normal. But it's even more difficult due to sheltering in place orders that we've had. You know, so now maybe I need to get some support, and I reach out, and the only way I can do that is virtually. And we can see here how difficult that could be, and that's starting this program tonight. But maybe I don't have access to, doing a video chat or doing that telehealth. Maybe I'm uncomfortable talking on the phone. The access could be very limited. And so this could be, uncomfortable, and maybe I just can't connect kind of humanly with someone that way. So people might be hesitant. And so that access, again, has another layer on it as a result of COVID-19. The next piece I wanted to speak to is talking about grief related to COVID-19. And, it's no wonder that during a pandemic that grief and loss are really paramount. Everyone is grieving the life they had in terms of being able to see loved ones, friends, coworkers, due to sheltering in place. They're grieving the loss of their job. They are really, really just facing that. And I would argue that the grief that we're seeing we're now at 100,000 plus of individuals who have died due to COVID-19. And so people are grieving their mothers, their fathers, their aunts, their children, their grandparents, their loved ones. And they're not able to really see that person before they pass away and have any kind of last kind of visit in terms of celebrating someone's life, kind of ceremonial going through what might help them in their beginning their grief process has been reduced or can't happen at all. I heard actually listening to a woman on the news, an African-American woman who said she had lost 30 people in her life to COVID-19. I can't imagine not being able to, work through that grief and be able to connect with people that I need to. And what we know through, and we'll talk about this a little further, is that, again, African Americans, Latinos are really being impacted by this. And so they're having more deaths that they're experiencing. And so that's leaving their communities really in that grief process. And so we're going to be seeing a lot of unprocessed grief as a result of COVID-19, which is going to then push that out to say we need some help regarding how to deal with that of individuals and the difficulties. And so there's going to be a rise in needing to really support people. And so, again, this is our current reality in a few areas that we just wanted to highlight. I think we could talk for hours about what people are experiencing. So we also know that COVID-19 is going nowhere. We are starting to see the United States opening up, but we have a long way to go. We may see some decreases in cases, but my guess is we're hearing from the research and scientists that we're going to see another spike. And so we have to manage this new temporary normal and be aware of the impact on our mental health. And those of you who, are on my Facebook page and see what I share, we've done 68 videos about mental health tips and trying to remind people how important that is. And so, again, these are 3 areas that we just thought were important to highlight, and we hope to hear from you towards the end about maybe what you're experiencing here. I want to move on and talk specifically before I turn this over to Nicole to talk about racial disparities in mental health. And so I mentioned about marginalized and minority individuals, families, and communities, and access and the lack of access for mental health. And so what we do know is that racial and ethnic minorities with serious mental illness are more likely to experience the use of psychiatric emergency services rather than community support services. And again, this is because there's nothing in my area, that access is not there, so I have to go and have the emergency service and get the help. And I can't have services on a routine basis. And additionally, there's a lot of stigma in minority communities about accessing services. And I would also argue that even if there's access, are we really equipped to address the needs of our minority communities. And so maybe individuals aren't going to come in because they don't think there's an understanding, which could be a problem. We also know that marginalized and racial and ethnic minorities are more likely to experience involuntary hospitalizations as a result of seeking care. And this is due to the crisis level that results due to untreated symptoms. If you don't get treatment, you're going to have increased symptoms, and you're going to be at a higher level of potential at risk of harming yourself and being in harm's way. And so you might be hospitalized involuntarily. So if we can kind of right-size that and begin to get access to services, that could reduce. We also know they experience emergency treatment as a result of law enforcement interactions. So law enforcement, a lot of times, have they see truly they lack understanding, about how mental illness manifests and the broken relationships that exist are there between minorities and law enforcement. How do we approach individuals, anyone with a mental health issue, but in particular, and we have seen what all of the issues are happening with our law enforcement related to minority groups. And then right now, recently, just Monday, and now what we're seeing in terms of how mental health kind of is put on top of that. So there's something called crisis intervention training that's a great course for law enforcement that they can complete because it helps them understand mental health, how to maybe engage with an individual so that their symptoms do not increase, and it may result in not having necessarily emergency treatment. But we see a lot of increase in emergency treatment because of this. There's also racial and ethnic minorities also experience an overdiagnosis of schizophrenia. In particular, African Americans with severe depression are more likely to be diagnosed with schizophrenia. And so there's research that was published in February of 2019 that talked about how the screening for major depression as a part of its assessment for schizophrenia in new patients. And so I don't want to get too technical here, but what we have to do is understand the symptoms that someone is presenting with, and we have to understand that related to someone's racial and ethnic community and who they are as a person and how those symptoms manifest and get the right diagnosis. But oftentimes what we see is there's this diagnosis of schizophrenia just attached when it might not be an appropriate diagnosis based on cultural and community factors. So we know that genetics, poverty, and discrimination, as well as the symptoms cause potentially of things that might have happened early in life, can really impact how that diagnosis comes to be later. And it could be really a misdiagnosis. But once you get that, you may not have the correct treatment because of the misdiagnosis. And lastly, I just wanted to mention that racial and ethnic minorities experience higher doses of antipsychotic medications. And so again, when we look at genetics, shared genetics, cultural, environmental background, it's clear that ethnicity is indeed an important influence on the psychotropic drug response. And so what we've seen in the research is there's differences in the clinical presentation, treatment, and response and outcome for mental illnesses based on one's racial and ethnic background. And so again, there's protocols clearly about what medication should be used, what dosages, but if we don't have a firm understanding of racial and ethnic minority groups and the individuals that we're serving, then we could actually harm them with higher doses, inappropriate doses of antipsychotic medications. And if I've misdiagnosed someone, I'm giving the wrong medication. And so we just really wanted to highlight this because this is a problem across the board prior to COVID-19. Now we're seeing the increase in mental health issues, and we're seeing that minority communities are facing the impact. They're losing more of their communities to COVID-19. So you can see how this kind of all will fit together, unfortunately, to exacerbate into a larger problem as we try to come out of COVID-19. So I've been speaking a lot, which I'm prone to do. So I want to pass this over to Nicole.
Okay, so when we look at kind of our systems within the mental health system, I think it's easy to say, well, everyone has access, but if the access is not appropriate and adequate for that population, then it's not true access. So we have inequality within the system. So these next few slides are just kind of a visual for kind of some of those systems level problems.
What is it?
Nicole, a girl I know, she's having a Zoom thing on.
Can you mute yourself? Thank you.
So equality would be, that we just raise everyone up. So increasing services across the board doesn't increase access for certain populations. So not really a solution to say, well, we'll just add more services if we're not making it proper and adequate for all populations. And then equity would be to increase services for just the populations where we're missing or they don't have equal access. And then justice would be fixing the problem, fixing the system, looking at why do we not have equal access, and what would it look like to just create a system that properly addresses everyone's needs.
And I just, Nicole, on that, I think it's important to say, right, if you think about COVID-19, and we're seeing in our healthcare system, right, those inequities and kind of that social, that injustice that we're seeing. And so physically and we're going to see this, and we know it exists for mental health too. Yeah. So I think it's really evident. Okay. So one of the things that is, I would say, a pillar of Kennedy Forum Illinois is sharing one story. And so let me say a little bit. The founder of Kennedy Forum is Patrick Kennedy, and then there's this Illinois, if you will, affiliate. And when I get together with the board members, we're on a meeting, whether it's in person or a conference call. It's everybody trying to understand our stories, and that we all have a story of some sort. We either ourselves particularly are facing something, or we know someone who has. When I talked about the statistics about Illinois, and then I said the 1 in 5, we're touched by mental health issues. And so I wanted to share just briefly that, kind of a little bit of a personal story, and, kind of try to make it safe and reduce the stigma, because that's what taking a seat at the table is about. And so I live with anxiety and depression, and I'm sure I've lived with anxiety for a long time. The depression is newer in my life, in the last years, maybe 3 to 4 years. But I would say it was hard to understand, because I think I'm what they call a high functioning individual with depression. So what you might see on the outside is someone who can get things done and always smiling, always happy. At least that's what I try to do, right? And it's different inside. And I think I want to share that, because just because someone looks a certain way or tries to present a certain way doesn't mean that inside that's the same thing they're feeling. Sometimes there's a real incongruence there, but it's just how to figure out how to get going and how to move along, right? And I think the stigma that exists, and we'll talk a lot about this later, but I know for me personally, it made it hard. And I'm in the field, and I don't think I have stigma about it for other people, but I was pretty hard on myself, especially as a clinical social worker, to think you got to have it together, and you shouldn't be the one dealing with this. And so I finally, made a decision to reach out. I engage in therapy, I take medication, and I try to pay attention, and I try to use my own tips, You know, and I often say that, well, if I'm saying it, I better do it. I'm not very good at it all the time. Sometimes I rock it, sometimes I don't. But I know that I have people around me that I can reach out to. And I think just because of my work in the field and being a mental health advocate, that I know that everyone has a story, and I'm not alone in that, even though sometimes I feel very alone in that on any given day. So you're welcome later. We can chat more about stories and ask questions, but I want to turn it over to Nicole here to share, talk about stigma.
All right. So when we look at stigma, we can talk about stigma within two different types. So the first type would be social stigma, where we're looking at prejudicial attitudes and discriminatory behavior towards an individual with a mental health illness. The second kind of stigma is self-stigma. So looking at kind of that internalization of the discrimination, or how people perceive themselves. People may perceive themselves as having a mental health diagnosis because of a character flaw, or because they have incompetencies. They may have low self-esteem, may hesitate to seek out treatment or adhere to treatment. And they may socially isolate themselves because they're afraid of discrimination. So they may lose out on job or housing opportunities because they've isolated themselves and just out of fear of stigma and fear of discrimination. So there's a lot of people from a wide range of backgrounds that have kind of some misinformation or wrongly held beliefs surrounding mental illnesses. One of the common things that you hear is that people with mental illnesses are dangerous. I think that's especially true with individuals experiencing schizophrenia or alcoholism or drug dependence. Kind of the attitude is that, oh, they're dangerous. Another would be that those conditions are self-inflicted. So I think sometimes one of the beliefs, misguided beliefs, if you will, is that they brought it on themselves, or they have control and they're choosing not to. So maybe someone with an eating disorder that's experiencing some negative health consequences from that. People may say, well, they're choosing that. They could just not do that behavior, and then they wouldn't have this consequence. Or especially with drug dependence, you see that a lot, where they're choosing to do that, and so they're choosing the consequences when it's really not that simple. And then that people with mental health problems are hard to talk to, and when in reality, you may talk on any given day to someone with a mental health diagnosis. You're unlikely to even know that you're talking to someone that has a mental health diagnosis. They're no different to talk to than anyone else. So stigmatizing beliefs about individuals with mental health challenges are held by a wide range of individuals, regardless of whether they know someone that has a mental health condition or have experienced it themselves. And even within the medical community, you see a lot of stigmatized beliefs within the medical community, and even mental health professionals have to really check their views sometimes. The media plays a huge role. When we look at stigma, you really can't even talk about stigma without talking about the media. It plays such an important role in those stigmatizing beliefs. Depictions of schizophrenia is probably one of the most kind of rampant issues within the media. When we look at how someone with schizophrenia is depicted in movies and television shows, a lot of times they're characters that are either homicidal maniacs or psycho killers in kind of horror movies. And those portrayals disseminate misinformation about symptoms, causes, and treatment of schizophrenia, as well as other forms of severe mental illness. These portrayals are not only incorrect, but they're damaging for several reasons. For one, schizophrenia, the portrayals of them within media often focus on symptoms such as visual hallucinations, bizarre delusions, disorganized speech, and present them as commonplace as if that's that all-encompassing of everyone that experiences schizophrenia. When in reality, things like decreased motivation, poverty of speech, and flat affect are much more common. But if you got your information about schizophrenia just from the media, you would not know that. Several movies have spread the false stereotype that people with schizophrenia are prone to violence or unpredictable behavior. And that influences viewers. We know that people are highly influenced by the media. And so that creates kind of these very negative, harsh attitudes towards people with mental illness. Another area where the media impacts stigma is within demographics, because if you look at movies and television shows, if you see an individual that's depicted as someone having schizophrenia, they're almost always depicted as a white male, when we know that disproportionately schizophrenia impacts African Americans and impacts men and women almost equally. On the other side of the spectrum, the media can trivialize mental illness too. They can make it seem like it's not as severe as it is, or not severe at all. An example would be eating disorders. When we see that depicted in the media, very rarely do you see the true seriousness of an eating disorder. And they rarely ever kind of talk about the ultimate consequences of the eating disorder. The reality is that the death rate for anorexia is very high, but you don't see that, you don't hear about that. They can also oversimplify things. An example would be obsessive compulsive disorder. It is so often depicted as this person that's just very cleanly and a perfectionist, and they just skip over all the kind of obsessive thoughts that drive those compulsions and the discomfort that goes along with that, and almost make it seem like it's this positive attribute. And, I don't know if you guys have seen the show Monk. He was highly successful as a detective because of his OCD, when in reality it can be very limiting. As a society that consumes tons and tons of media, and we have social media that we're constantly on, looking at how do we stop adding to negative stigma. I think things like using words like crazy add to stigma. Using diagnoses in a non-clinical sense add to stigma. So you hear, I think OCD gets used a lot as someone's highly motivated by, making sure details are right and perfectionistic, then people will say, oh, well, that's just their OCD, or even say it about themselves, like, oh, I had to clean my house, I guess that's just my OCD. You hear it with ADHD too, where someone has very high energy, or maybe a little bit forgetful and inattentive, then people will make a comment about, oh, I guess that's just their ADD. Giving that label to someone in a non-clinical sense is damaging for the people that are really living with those illnesses. Either, using it in a positive sense of that it's some sort of superpower, they're so ADHD, they can just get everything done, really is kind of limiting for an individual that truly lives with ADHD and understands the limitations involved. So stigma embraces both prejudicial attitudes and discriminating behavior towards individuals with mental health challenges, and the social impacts are detrimental. Some of the social impacts can include like social isolation or exclusion, poor social support, poor quality of life, and there's even physical health consequences due to stigma creating this kind of scenario where people aren't getting the treatment that they need. And so there's all these negative consequences for them, not just with their mental wellness, but their physical wellness as well. And then low self-esteem. So when we look at how do we break this trend? How do we reduce stigma? We do it by opening up about mental health and sharing our own stories. So I would be remiss to stand here or sit here or whatever today talking about stigma without sharing my own story. I have had struggles with my mental health my entire life. As a child, I struggled with social anxiety and generalized anxiety. I was very uncomfortable in a lot of spaces. I would cringe if a teacher assigned a group project or at the thought of attending a social event where I might have to interact with people that I didn't know well. My anxiety made it difficult to concentrate and function at school. Homework became arduous, and I would put things off until the last minute because I would be so anxious and worked up about starting it and just would get myself very overwhelmed. In college, I dropped one course as a result of my anxiety. The professor had assigned a group project, and I had so much anxiety over that I dropped the course. And it was an important course for my degree. And I failed another course over my anxiety. As a result of my anxiety, I really struggled with self-esteem, especially when I was younger. I felt inept in a lot of social situations, and that set the tone for depression. I struggled with feeling like I was not good enough. In high school, I really struggled with feelings of hopelessness. I felt like things were hard and would always be hard. Sometimes it felt like I was looking through a tunnel, that I could see the light at the end of the tunnel, but that darkness that was living with depression was kind of so encompassing that it just felt overwhelming to try to break through it. Following a suicide attempt, I started counseling, and things did improve. Counseling helped me work on my anxiety and depression. It helped me build coping skills, grounding skills to kind of deal with that anxiety when it happens, develop better social competencies, and even make some friends and kind of build up my social support network. As an adult, I've continued to struggle with anxiety and depression at times, but have skills to manage it better now than when I was younger. A combination of medication, therapy, good exercise, and prioritizing sleep allows me to stay on top of my mental health. Even with a great self-care routine, though, some things can still throw me off track. You can have the best plan in the world, and you can't plan for some things. Earlier this year, my mother passed away, and with that brought grief that I had never experienced before. I really had to reevaluate what was working for me and what wasn't in terms of my mental health. I had to make a concerted effort to reach out and connect with others and have open and honest conversations with both my doctor and my counselor. Struggling with your mental health can feel very lonely at times. You start to think you're the only one that experiences this, or you're the only one that has thoughts like this. Even when you work in the mental health field and you know that's not true, that depression can take hold, and you just feel very alone within that. Connecting with others with similar challenges has been really empowering for me. But we're only able to do that when we can talk openly about our mental health with others. If we're going to reduce stigma, we have to start talking about mental health and keep talking. Brené Brown says that you can choose courage or you can choose comfort, but you can't have both. I think that's really applicable for this conversation, is that it does take courage to throw yourself out there and say, I'm struggling. It's very vulnerable. So today I chose courage, and I would challenge you to do the same.
Thank you for sharing that, Nicole. So what we want to do now is open for questions or comments. And I don't know, let's see, we've got some chat comments. I don't know if they're, let's read through this a little bit. It says, are there statistics showing the mental health impact on nursing home and assisted living residents? Being isolated to their rooms since February has taken a toll on my 87-year-old dad's mental health at the assisted living center and physical decline with not being able to walk around. Gail, that's a really good question, and I have not seen that yet. And I think right now, I think they're focused on, my guess is kind of with right now, especially with COVID-19, on how to keep people as safe as they can, because we're losing so many people there.
Mhm.
But I have not seen any research yet on that. But I agree, it's you bring up a really good point about older adults, and that sometimes I think there's an assumption that they should be, you know, that they're supposed to be depressed. I mean, they're old, they're, you know, and that's not true at all. There's no assumption. They can't experience depression, they can't experience any kind of mental health issue, but it's not the norm. And so this is going to have a big toll on them, I think, of being so at risk.
And I think we can, while there's not current research out yet, I think just looking at some of the other research just on like social isolation in general, our brains are wired for connection. So I do think we're going to see like major mental health impacts from this.
Yeah.
I appreciate your input. Thank you. And I think the window visits have been a very positive thing for these folks, but sadly my dad's on the 3rd floor.
Yeah.
And so he loses out on that also, but the window visits have been powerful.
Yeah. Yeah. And it's, I mean, for your dad and what you're trying to do to support him and do that, and what you're experiencing too, it's got to be difficult. I know that every day I go for a walk and I walk by a particular rehab facility, and I wave. Every time I go by, I try to wave, and sometimes I get some response depending on what they're doing. But it's a really isolated group of individuals. We'll have good thoughts for your dad. It's a very tough situation.
Thank you.
I wonder if you could float balloons by his window. Oh, that's a nice idea.
Oh, that's awesome. Thank you.
That's from Risa.
That's a great idea.
So you guys, we have, there's 24 people on here. I think we can manage this. If someone would, if you want to kind of reach out and say something, you don't have to put it in chat, or you can, but what are some thoughts or comments that you'd like to talk about? I feel like I'm Professor Garrison.
Hello.
Hi, Ed.
Hi. Yeah, I was just I had actually 2 thoughts on the issue of stigma.
Okay.
And Mary, I apologize if I'm repeating a story I may have shared with you already.
Oh.
But I had one of my advisees had applied for an internship with the FBI.
Mm-hmm.
And one of their standard questions on there was, had he either been diagnosed or treated for mental health issues?
Mm-hmm.
And he honestly reported, yes, he had when he was
Mm-hmm.
a youth,
Mm-hmm.
and he didn't go into any more detail with it.
Mm-hmm.
Well, the bottom line for his situation was his practitioner had retired,
Mm-hmm.
and nobody was able to locate records and respond. And so basically, he was denied the opportunity for an internship because of the stigma associated with an unconfirmed previous diagnosis. And when I tried to talk with the student about it, I said, I'm sorry for that, but where do you think that leaves you? He goes, well, you talk about trying to reduce the stigma, but if you don't have a way to talk to the people who aren't the choir, the people who make the decisions, what good is it? If they're the ones holding the stigma,
Mm-hmm.
it doesn't matter if we talk openly about it.
And Ed, it's unfortunate that that's more common, right, in certain professions. And here he is being honest, and no one would have known if he said no, because there was no records, right? And so he's trying to destigmatize that and say, this is who I am, and I have. And I think that's kind of when we look at entities like Kennedy Forum Illinois, we look at the National Alliance on Mental Illness and Mental Health America, really trying to reach out to these places and to not the choir, but to everybody else who needs to understand that because of a diagnosis, past, current, that doesn't have to preclude you from doing a job or doesn't mean you're broken. It means, okay, how was that for you? And actually probably be better at doing the internship than a lot of other people because of his experience, right?
Exactly.
And so there's definitely incongruence there where we are trying to do this. It takes this direct conversation. And one of the things that Kennedy Forum does every year is they do a forum. And last year it was on like in the workplace. And we talked about how that employers, bosses can say, what are we going to do for our staff? How are we going to support them that they can call up and say, I don't have the flu, but you know what? I'm having a really rough day and I'm going to stay home today because of my depression, and not feel like they're going to lose their job over that, right? And how we can support them. And so there's efforts being made, but I've been doing this for 30 years. It's getting a little better because we're willing to share our stories. I think it takes, we have a lot of celebrities that will share. They've been a part of our forums. Michael Phelps is recently, he was with us last year, and he recently, due to COVID, was sharing. I have no answer. I could ramble for days. It's a tough one.
Right. I guess my question is, do you know if practitioners have a means of letting their clients know, if you have, someone, challenging you, here's the resource to go to. Here's someone who can be an advocate on your behalf? Because it seems like the people who are, being stigmatized against, they're already feel like they're in a corner and they feel like no one has their back or is able to support them.
And I think the practitioners themselves could do that with the individual's obviously consent. I think it's about providing, data for that. And you're talking about this internship at the FBI. That's a tough one, right? That's like
Right.
the pinnacle. But I do think if you're talking about at work, your human resource folks should be able to support that. But I think your practitioner, it's a great conversation also about how you frame your story and let them know your story and where you are and what your supports are. And that's where I think an individual oftentimes is much more successful with the supports they have around them than rather trying to just do this on their own. And so if someone can share their story and say, yes, I have times where I struggle a lot, but here's what I do, here's what I need, I think that could help reduce that. We found that with the employers that they ended up having, bosses telling their staff that they're struggling too, and really that human connection. And it broke down, kind of that chain of command a little bit. Yeah, you're still my boss, but you're a human and you
Right.
have that. It's tough, but I think practitioners, we talked about, we might have stigma too, right?
Mm-hmm. Yeah.
And
Absolutely.
I think we have to really check ourselves and make sure that we're on top of that, and to say, wait a minute, this, let's have an honest conversation. Yeah.
And the other piece on stigma, a different student had approached me a couple years ago, and he was really wrestling. You could tell he was really wrestling just with himself, because he had gone through the process and received an accommodation letter,
Mm-hmm.
but he really couldn't decide if he wanted to share it with me or not. In other words, he was really wrestling. I don't want to feel like I'm being treated differently. I don't know if I'm ready to do this on my own, but and the struggle was palpable. And the thing is, so that particular individual, you could see, was wrestling with, and I don't know whether it was the stigma per se or just, his own situation, but it's one of those things where empathy goes only so far. And sometimes a lot of us are just, well, what do I do? What's the right way to respond?
And that's really hard. And we've had a lot of discussions here at Millikan. I have, with kind of, Provost Daper and Vice President Prangy about how we can begin to, again, we need routine conversation. And people, I'm fortunate enough that I work in the field. It's a little different for me to address with my students and to talk about than someone who doesn't have maybe that background, but doesn't mean they're not as capable. And we just need to help students understand that we're approachable. But that's breaking that down too. Whatever, I've heard some situations where a student was told that they weren't believed that they had depression, that they were just lazy. And how to combat that. No wonder you'd be terrified if you went to another professor and said, hey, Ed, I need an accommodation, or this is going on. And so we have to work with not perpetuating that stigma. But I think part of the problem, and Nicole, gosh, I'll let you talk maybe, is that we talk about it and then we don't. Like, I think May is Mental Health Month, we talk about it. And then we need to talk about it all the time. And not that I need to talk about my personal story all the time, but we need to be recognizing and making it safe and figuring out how to do that. And I really feel for the students. And we have an increase in our students, right? Students are coming to campus more with situations they've been dealing with, mental health diagnoses. They're coming with medications now, very different than even 5 years ago. And we need to be there to help support that. So, thanks, Ed. Who else wants to, maybe got a chat?
I was gonna pipe in, Mary, in regard to what Ed was saying in regards to stigma. Maybe we need to start astigmatizing it by putting it this way. And because when I'm dealing with students at a school, when I do my classroom presentations, I try to make them understand that everyone has mental health.
Mm-hmm.
And I try to take the word mental illness away because it's negative in nature. People get negative feelings about using the term mental illness because it makes it sound like they are mentally ill and they're going to be mentally ill forever. That's not the case.
Mm-hmm.
So I try to get them to understand that if you have a brain and you have emotions, you have mental health. Mm-hmm. So mental health. Everyone's going to struggle with depression at some point in time. Everyone's going to struggle with some sort of anxiety at some point in time. It's all, someone could have such problems with certain types of mental health that it could cause a lot of problems in functioning at home and at work. Mm-hmm. I try to get rid of the stigma that way with a lot of my students so that they understand that my door is always open and I'm there for them when they're struggling with something, regardless of what it is. And then as far as like FBI applications, as a disabled veteran, and I was a military spouse for 7 years, military has come a long way. You used to not be able to talk about your mental health concerns, but they have realized after the extensive long war we are currently in and all the deaths that we've had and the grief we've experienced as soldiers and the military, they've realized that if they don't start doing something about it, our suicide rate increases exponentially. Mm-hmm. So what the military started doing back in, I'd say it was 2006, 2007 timeframe, was they started having candid conversations with these spouses and soldiers in regards to mental health and started doing screeners before and after deployments to address the suicide risk. Mm-hmm. So when it comes to this pandemic, I sort of, yes, it is a pandemic, it's a medical issue, but I sort of view it in the way trauma is. This pandemic trauma, and in my mind, when we have people seeking mental health services and medications have increased for anxiety and depression, I really think it's trauma related. And I think we are going to see a lot of problems in regards to when we start trying to return to the way prior to, because a lot of people are going to experience anxiety about, am I going to get sick if I'm in a crowd? Am I going to get sick if I go see my doctor? And I think the best way to handle this situation is to normalize it, that it's okay to feel this way.
Right. Absolutely. Angela, those are really great points. And you got me thinking about trauma, right? And how that fits in to so much of this, right? And the impact of that and how that may present through an individual. And we don't know what's behind that story, what someone is holding on to or has worked through or not worked through, or is living right now. And it is trauma. And we have trauma-informed care. We're getting better at that. That it's a great point to make, especially how you talk up to your students, that we always talk about like a three-legged stool. You have mental health, physical health, and your spiritual health, whatever that looks like. We need all of those, right? I mean, we treat our diabetes, we treat our heart, we need to treat our head. So
I think the kids are kind of key to reducing stigma too, like teaching them young that it's okay to talk about this, it's okay to not be okay all the time, and that expressing your feelings or whatever's going on with you is okay, I think can be really helpful.
we have a question in the chat. Talks about, I'm particularly worried about students, especially as we continue on potentially into the fall with more significant changes due to the pandemic. Studying, staying focused, obviously is difficult. I think some teachers and faculty do not always take into account the significant impact that mental health has on students' performance. When students miss class for, quote, mental health day, it is sometimes seen as different than because absences due to something like strep throat. From an educational perspective, I wonder what both of you think. How do you help faculty and teachers realize that students do need a break? And that sometimes it's not just them making up an excuse, right? And therein lies the difference. Why do we believe strep throat? If I tell you the flu, you're like, okay, great, yeah, don't come to class. You have no idea if I have flu or not, right? But I tell you I need a mental health day, my anxiety is literally, or my depression is crippling me that I can't get out of bed today. And we say, well, what's your problem? And I think that comes down to how faculty need to be educated and understand that. And, you know, I do and talk with my students in class, and I really try to say, you just communicate with me. One, maybe I can get you to a resource. But I think we have to, as faculty, normalize that and do kind of what Angela was talking about. You know, this is the same as your physical health. And so I think we have to present that. And I saw a little bit down here that, if I may, you know, Ed said, I'm wondering what this looks like if we tried to build into our syllabi the context of X number of personal health days, which include health days of all types. I think that's a nice idea. We need to talk about mental health in our syllabi. We need to talk about that when we're opening up first day, and maybe when we know things are getting more stressed and not. So it's a constant conversation.
I think there has to be more education on it for all, you know, we do a really good job within the mental health community of educating ourselves on trauma and on mental health, but educating others so that they have a better understanding. I think that, you know, there's such a spectrum with how depression or anxiety or any mental health illness impacts someone. So if you have someone that's experienced depression themselves and was high functioning and able to push through, and they're not educated on mental health issues, then they may think, well, this student is just milking it. They could just buck up and move on, when that's not realistic for that student. So kind of educating people that mental health illnesses impact people, every person differently. So I think that's key.
I think there's also something said for, you know, kind of even getting away from academia, but it can happen in academia, but other places, is that, you know, we tend to wait to get our mental health needs met, if we even do that, until we're close to a crisis, maybe, right? And again, I will say this comes through Kennedy Forum, that Patrick Kennedy coined, that checkup from the neck up. And, that why we go for our physicals, we get our teeth looked at, we do these things, we pay attention to, the vaccinations we get, everything as we grow up. What about having conversations about our mental health and making sure we check in with someone? And that could be your primary care provider. And there's some now access is getting a little better in our healthcare entities that are serving more marginalized populations, that they're having that behavioral health attached. So trying to integrate that. But I think we need to be a little more proactive maybe. But again, that takes us to help support that.
And I do think the attitude is there that, you don't go to a therapist until you're just really far gone. I've had people say, when I've had booths out offering different resources for mental health, say, oh, well, I almost went to a counselor last year, but I wasn't that far gone. Or, you don't have to wait until you're in a crisis. You wouldn't wait until you were in a physical health crisis before you went to your doctor. So, getting to the point where we see that more as, the checkup, where I'm feeling a little bit not myself, so I'm going to go now before things get worse.
If I can say one thing positive about COVID, which is hard to do, it is sure, unfortunately, it's brought up all the mental health issues, but the resources and things that are being pushed out to people, I'm hoping people will realize that I can latch onto those and I can use those. I mean, we're getting to have a seat at the table, if you will, to talk about this. Other questions? Comments?
Mary, there was an earlier question about people working from home. Could you see that in the chat?
Barely that I can get in the chat, Ed, with my technology experiences.
Would you like me to read it? It was Stephen. Or Stephen, if you're there, could you unmute your mic and go ahead and
Stephen,
bring
let's
your question?
chat. That's great. Talk to me, Stephen.
Hi, it's good to hear from you guys.
So good to see you.
Okay, so my question was really about people who, so there's people who are getting laid off, there's people who are experiencing furloughs, and then there's also people who are working from home. A lot of the times what I'm seeing is that a lot of people are trying to juggle all these hats at the same time. Like, I've got to be dad, but I also have to work remote, but I also have to engage in these responsibilities. So how do we encourage people who are working from home to seek mental health when necessary and to utilize self-care? And then my other question is, as far as people who have been laid off or who are currently unemployed because of COVID-19, how do we encourage them to seek mental health resources while they're still trying to find gainful employment with benefits?
I think reaching out and kind of normalizing that this is not normal, right? That this is not our normal scenario. We've never done this before. This is new for everyone. And so talking to people about having self-compassion and giving yourself some grace that, we are all experiencing our roles in much different ways. Like you said, some of us are working from home where we normally worked in an office or in a different setting. Some of us are working from home and have small children at home. So now we're, educators and working from home, and then also kind of balancing the not being able to go places and do the things that we normally do. And this is not something we've experienced before. So I think talking to people and just kind of normalizing that this is a struggle for a lot of people. It's okay to not be okay, and it's okay to reach out and get those services, and letting people know what the services are, what's available and out there. So,
and I think too, one of the things I know that I personally experienced was that I had to become an incredibly amazing online professor. And those students, alums that are on, know that that's not my gig. It's not going to happen. And so I really struggled with that, having to do my job in the way I thought it needed to be done. So my level of anxiety just flew through the roof. Nicole got to experience that in some stressful calls, and I was like, I can't do it, well, I gotta quit, and just thinking, how am I gonna do it? And there were some cool articles that said, don't be the perfectionist we don't want you to be, right? So because it's a unique situation, let's right size this. And then a lot of the information that's out there talks about you have to set some routine. Now, it's not going to be maybe the routine you want, but you got to figure out, okay, here's when I'm going to have to work out with my supports if I have them. If I don't have them, here's how much work I can do. You have to chunk your time. One of the things that I think in the beginning was like, oh, we're closed down until, April, whatever, 10th. Oh, got it. No big deal. Now, it's been further and further. And I think it's getting worse for people, right? Because they could say, and again, those that are on that have me in class, I can do anything for a period of time. Well, that period of time keeps growing. So I try to chunk it, and I have to reset my schedule. I do. If I normalize it in the best way to get dressed, make sure I'm in that motivation piece, Stephen, that you bring up is really important. I think we've all experienced that at some point. We've lost it here. There's days I'm like, I'm done. But if you can get up and get in some of that routine, and I know that it sounds really easy, right? Like I can rattle off, as I have, 68 mental health tips, but something's going to work for somebody. And then it is the next of, when do I need to reach out? Like, if this is a temporary, if you will, period of time, maybe I'm still okay, and we push it away. I think I'd want to tell you, if I were around you and saw that you're struggling, I might say, hey, have you ever thought about, you're looking really stressed, and encourage people, and maybe sit with them if they make the call, those kinds of things. That could be helpful. My gosh, the people that are literally trying to, pay their next bill, keep a roof over their head, because it sounds like the roof will be over their head until a certain time, right? So there's these things in place where people can't be evicted, they can't, all these things, but in the big picture, that's got to be really scary, because magically someone just doesn't give them money to pay their past rent, or to do things, or to get them another new job or go back. And those offer some different challenges for people. The system, that people can't get their unemployment. I know that systems, from some people I'm friends with and know, have been challenged by that. Feeling like you're a part of a ton of people who are in the same situation, but when you're sitting in front of your computer trying to do it, you don't think of that. Oh, I'll be okay. Everybody else is. This is about you, and you matter, and you're hurting and struggling. It's a tough. I think it's about the constant contact to those folks that we can reach out to and know that are dealing with that. And when we can't, I like what you talked about having that grace for ourselves, and
other people too.
Absolutely.
I think remembering that other people may be experiencing this very differently than we are. And especially recently, with the states just starting to open up, and everyone has a different opinion on how that should happen and when it should happen. So I think that's an important piece, is just having grace for other people too.
Yeah. Great question, Stephen. Other comments?
Great answer. Thank you so much.
Sure. Guys have any? Oh, we got another question over here. Now I'm getting the hang of this, right? Maybe I can do online teaching. Do you have any advice for parents who might have children that are depressed? Great question. So since the pandemic, my son has been more depressed. Sure. And that's, Emily, that's a natural and kind of expected response, because of not only what your son has experienced, but my guess is just, how you as parents are reacting to, and what, everybody's feeling, right? Everybody's kind of feeling off of each other. One of the things that I have been reading and learning about for children, since I don't have little ones at home, but is to, really kind of give space for that, right? Like let kids really express themselves and understand a little bit what's going on. And I'm going to refer to my good colleague Nicole, who has 2 little ones at home.
I think, like what you said, just allowing space for them to feel whatever it is they're feeling, and remembering that with all of this, there is a grief process. The grief isn't just when we lose someone to COVID or during this time, but there's a grief process for things that we've lost, that sense of normalcy, that being able to connect with their friends and go to school and have the closure at the end of the school year. I think it's very normal at this point that they would be experiencing some depression as part of that grief process, as part of things just not being what they normally are. So kind of talking about that with them, of you've experienced a loss here, and that's kind of in those age appropriate ways of communicating with them.
You guys, it's about 8:25. So I'm thinking we're going to wrap up. And what I'd like to do is offer up our emails if individuals want to follow up with questions. And don't you love our little, what do we call them? Bitmojis, see? But of Mary and Nicole here on the screen. But so my email is mgarrison, MGARRISON @Millikin, MILLIKIN.edu. And Nicole?
Mine is NEKISS @CAMRaiders.com.
So we both welcome future conversations. If you guys want more, we have tons of resources. I think we're just really grateful that, we're always happy in mental health when one person shows up. Yeah. And we scored with 21 of you, and we appreciate that you joined us today, and want to thank you and hope that you will get a checkup from the neck up and take care of yourselves during COVID-19. So with that, we will say goodbye. Bye.
Thank you.
You're welcome.
Thank you much.
You're welcome. Thank you, Ed, for making it happen, literally.
Sounds good.
Appreciate
See you
it.
later.
Bye.
Thank you, Mary and Nicole. See you later.
Good to see you.
Good
Bye.
to see you.
Bye.
No, that's good.